Hello, my name is Arturo Jaime. This is my nutrition support case study. So, upon admit, we have Mr. RT, who is a 33-year-old male. He is 6'3 or 191 centimeters, no reported usual body weight, a first measured weight of 119.3 kilograms or 262 pounds, and an IBW of 196 pounds, with a BMI of 34.1, which classifies him as obesity grade 1. He has a past medical history of esophageal spasm, a liver abscess which was drained 6 years ago, and no reported home medications. He has an admitting diagnosis of Boerhaave syndrome, esophageal perforation, retroesternal chest pain secondary to esophageal perforation. So, Boerhaave syndrome is actually uncommon and is the perforation of the esophagus, which is induced with vomiting or any sort of pressure that is occurred right there in the esophagus. And so, the actual definition is a sudden rise in intraluminal esophageal pressure produced during vomiting as a result of neuromuscular incoordination, causing failure of the cricopharyngeus muscle to relax. And so, it is often associated with overeating and/or drinking excessive amounts of alcohol. And so in my picture, you can see exactly where it most commonly occurs, which is the left postlateral wall in the lower third of the esophagus, right above the stomach. And so most common cases are the men between the ages of 50 to 70, and it can be difficult to diagnose as there are no classic symptoms. It often leads to sepsis, shock, and mediastinus, or which is the inflammation of the mid-chest or mediastinum, and it has a high mortality rate, and survival is a matter of days. And the best outcomes often stem from surgical intervention within 12 hours. And so, since the esophagus is actually ruptured, we want to make sure that we're bypassing and not having any sort of PO intake, which would cause that irritation or infection or any sort of complications like that. So, therefore, we bypass into the jejunum. And so, day one, the initial assessment, we were consulted for EN, and the patient is intubated and has a PEG tube already placed for feeding. And so, for his estimated needs, I calculated using the Penn State, which provided 2,408 kcals for the day, or 20 kcals per kilogram, and protein at 119 to 143 grams per day, with an increased needs of 1.0 to 1.2 grams per kilogram, and fluid at 1 ml per kcal, or 19 milliliters per kilogram. And so here we recommended Peptamen AF, and the reason we recommended Peptamen AF was because of its high protein and also implications for GI dysfunction, impaired GI function or dysfunction, which was in this case is the case. And so this would provide 1,446 kcals or 2,000 or actually 2,568 kcals with propofol, 117 grams of protein, and 875 mLs of free H2O. Flushes were to be 250 mLs per every 4 hours, and this would provide 100% of estimated kcal and protein needs. And you can see on my graph how it provides 100% of all estimated needs. And so the PES is inadequate oral intake related to intubation, as evidenced by the need for EN to meet more than 75% of estimated needs. So day 4, we were to clarify the tube feed order, just a quick checkup, and he was now extubated and the propofol was DC'd. And so here he was actually only receiving 40 milliliters an hour of Peptamen AF, so this was providing 64% of kcal needs, 40% of protein, and 43% of fluid, and only 64% of the DRI. And so for the formula, estimated for estimated needs, since he was now off the extubated, we used kcals per kg, and it was still first measured weight, which gave us 1,790 kcals to 2,386, or 15 to 20 kcals per kg. Protein and fluid stayed the same. And so now, since the propofol was DC'd, we recommended increasing the Peptamen to 83 mLs an hour, providing 2,390 calories, 151 grams of protein, and 1,615 mLs of free H2O, flushing to 120 milliliters every 4 hours, which would provide 100% of estimated kcal and protein needs. And so on the day 8 for the follow-up, he was receiving 83 milliliters an hour, which was the recommendation, which gave him 100% of all estimated needs. And the estimated needs continued to stay the same in this case with the first measured weight. And so he continued to improve and was now getting up to use the restroom on his feet. So the MD noted to continue his pulmonary exercises continue the 2 feed in strict MPO, and the gastrografin procedure would occur in the AM, which would cause his 2 feed to be on hold. And so his PES statement was now inadequate oral intake related to Boerhaave syndrome, as evidenced by the need for EN to meet more than 75% of estimated needs. And so on day 10, he was receiving the Peptamen AF at 83 milliliters an hour, and he was advanced to full liquid. So his clear liquid intake on the past day had been an average of 79%, and I recommended decreasing the EN when PO intake was consistently over 75%, and continued to advance his diet as medically feasible and as his swallow allowed. Day 11, his diet was advanced and he was consuming 50% of his breakfast, but the EN continued to run, and so we recommended changing his 2 feeds to nocturnal cyclic feeds and to allow for oral intake during the day. And so his new recommendation would be Peptamen AF for 100 milliliters an hour for 12 hours, which would provide 60 to 54% of kcals and 76 to 63% of protein. And the estimated needs would continue to be the same. On day 13, he was doing well and tolerating PO intake, and he actually refused the 2 feed the night before, and his oral intake was around 93%, so I recommended decreasing his 2 feed, as patient was now eating over 80% of his meals, and advancing the diet as medically feasible. And so for his labs, you can see he was clearly high for his chloride, and that may have been due to acidosis, and potassium might have been low to trauma, and the calcium inversely related to the low albumin, and the albumin due to the acute inflammation or infection. And so that is my presentation. Thank you.